I'll be presenting our implementation of continuous PEG-asparaginase dosing without an asparaginase-free interval in the treatment of children with newly diagnosed acute lymphoblastic leukemia. And these are the results of our Dutch Childhood Oncology ALL11 protocol. So we did a PEG-asparaginase randomization in this protocol. And what we saw is that this significantly reduces hypersensitivity to PEG-asparaginase. Asparaginase has been used for quite some time in the treatment of ALL. And so it's a key component of ALL treatment. And unfortunately, hypersensitivity is a major side effect of asparaginase treatment, and it really hampers its use. So what we've observed is that most hypersensitivity reactions, they occur after an asparaginase-free interval, which is typically defined or termed as 3 to 4 weeks of treatment without any asparaginase. And what we see during these intervals is that there is an increase of anti-drug antibodies. And so right after a break, when the patient's starting asparaginase treatment again, there's a buildup of these antibodies, and a lot of patients have a hypersensitivity reaction right after this break, triggered by these antibodies. So our hypothesis for this randomization study was that we would design a treatment, asparaginase treatment, without an asparaginase-free interval. So continuing treatment right after induction. So we randomized patients. All patients first received 3 PEG-asparaginase doses in the induction, and then standard treatment there would be to have a pause in your treatment. And in this protocol, in our protocol, it was 3 months without any asparaginase. And then they would continue with receiving 14 PEG-asparaginase doses, which are standardly giving bi-weekly, so every 14 days. And then our experimental arm was after these 3 doses in induction. The experimental arm directly continued their PEG-asparaginase treatment, and they also received a total of 14 doses post-induction. And what we saw is that it significantly reduced hypersensitivity reactions. If we specifically look at inactivating reactions, because we have defined 3 different types of hypersensitivity reactions. So we have clinical allergy and the silent inactivation, which are both marked or characterized by inactivation of asparaginase. So a clinical allergy is where a patient has allergic symptoms, and we also have confirmed inactivation of asparaginase, and a patient needs to switch to a different formulation, and there's no cross-reactivity with Erwinia asparaginase. So most patients are then, if possible, switched to Erwinia asparaginase, which is a good supplement. And then we have a silent inactivation, where patients do not show any symptoms of an allergic reactions, but there is inactivation. So these patients also need to switch to Erwinia asparaginase. And the third type of hypersensitivity is an allergic-like reaction, which is where a patient has the symptoms of an allergic reaction, but there is still activity of your asparaginase enzyme, so the patients can just continue their treatment with PEG-asparaginase and finish their treatment. So we specifically look at these inactivating reactions, which would be the sum of your clinical allergies and your silent inactivations. We also saw that these were significantly reduced in the continuous arm. So if you take away that asparaginase-free interval, and I believe it was a 7-fold reduction, so it was a quite significant result. We also looked at other asparaginase-associated toxicities, such as infection, lymphopenia, thrombotic events, pancreatitis, and vascular necrosis. And here we didn't observe any differences in the total amount of these incidents or these adverse events. But we did see a difference in the timing of these events. So, you can imagine that if there wasn't any asparaginase given, so for example, during the break in the standard treatment arm, we saw less asparaginase-associated toxicities, whereas patients who did receive asparaginase during that break, because they were in the experimental arm, so they continued their treatment. There we saw that there were more asparaginase-associated adverse events in the experimental arm. And we also then, as a last endpoint, looking at the outcome, we didn't observe significant differences between cumulative incidence of relapse and that in the first remission. Overall, we're very happy with this study that we were able to show that the design of your asparaginase treatment can have a huge impact on hypersensitivity and reducing the incidence. So we're very happy with the results of our study.